All right, welcome everybody. Let's get started. Let me find my notes. All right, so for those of you who don't know me, hi everybody. I'm Ray Sidney Smith, and I sit on the board of directors of Pittsburgh Equality Center. And tonight we're doing another one of our LGBTQ town halls. And tonight I have the pleasure of having Dr. Ken Ho here, and we're going to be talking about sexual health in light of all of the things that are going on in the LGBTQ health spectrum. And we are going to have a conversation, and Dr. Ho is going to answer many of my questions, and then we'll kind of close out and go from there. So I'm going to give a little bit of introduction to Ken, and then we'll get into this. So Ken Ho is certified in infectious disease and internal medicine by the American Board of Internal Medicine. He's affiliated with UPMC Mercy, UPMC McGee Women's Hospital, and UPMC Presbyterian. He completed his residency and fellowship at the University of Pittsburgh School of Medicine, and his medical degree is at University of Maryland School of Medicine. And so, welcome, Dr. Ho.
Thanks for having me. Happy Pride.
Happy Pride to you as well. And so, I'm like I said before, I'm Ray Sidney Smith, and I use he, him pronouns. Ken?
I use he, him.
Wonderful. And so let's get started off with the kind of first and biggest question, which are, what are the biggest challenges faced by the LGBTQ community when it comes to accessing quality sexual health care? I know that even as of last year, I had a conversation with you about not being able to access the monkeypox vaccine because of all of the various bureaucratic kind of hurdles. What do you feel are the biggest challenges facing the queer community right now in terms of that?
I mean, you sort of said it right there. The problem is access half the time. We have a system where we do amazing things. We have so much in terms of like innovation, technology, what have you, but it's only accessible usually to a very small group of like privileged individuals as opposed to entire communities who probably need those benefits more than others. So yeah, I mean, I think community has responded to that challenge in different ways. There are, for example, I think communities that have, clinics that have formed in the community space, and I'm thinking of places like Allies for Health and Wellbeing, Central Outreach, PERSAT, where they kind of are of the community and for the community, and I think that has been a nice response, and probably one direction where we do need to head. But there are also, I think it's also a matter of looking at the existing institutions which provide excellent quality care and kind of reflecting on that and trying to figure out like how do we make these spaces more inclusive of everyone. And that's a question that takes a lot of work.
Yeah, one of the things that we're actually working on at the center is a gender affirming care guide to be able to put together all of the resources that are from major care providers like UPMC and Allies for AHN, Highmark, and making sure that is all accessible from one portal so people know they can go to Allies for Health and Wellbeing. They can also go to their primary care providers under one of the major brands and be able to get access to it. But it is certainly something that continually needs to be kind of educating the population about where care is provided and how they can access that affordably. I wanted to move on to talking about how do you feel like, as just yourself, but also any other member of the queer community, how do we navigate a healthcare system that may not be familiar with being an LGBTQ person and satisfying our needs?
Yeah, I don't know that there's like a one right answer. My own personal opinion is sort of being scrappy, so to speak. And I think by that, I mean just being tenacious, not taking, oh no, that's it for an answer, but being like, okay, this is what I need and how do I get there? And if you hit a barrier, how do you get around the barrier? And unfortunately, that does sometimes take a lot of work. Sometimes it takes kind of digging around and using the internet a little bit, talking to people, because usually there is somebody in that space who can actually navigate the system very well, and you can sort of benefit off that expertise, whether that's somebody who actually exists within the system or outside of the system. And I think within public health, we've come with the concept of these like healthcare navigators who are people, okay, yes, they're good at this and they have the connections, to get people into the right spaces and places. And so that's another piece as well.
Absolutely. I'll plug the center here again, just letting everybody know that you can always email info@pghequalitycenter.org or call our number 412-422-0114, and we'll be able to answer questions relating to where you might be able to find and access those kinds of healthcare resources. We're always happy to help in that regard. I think we've already talked about the idea about resources. So I wanted to come to your kind of specialty, which is infectious disease, right? Are there any specific STIs, sexually transmitted infections, or STDs, as some other people use the term for sexually transmitted diseases, that are more prevalent within the queer community today? And why do you feel like that's the case? And I think the corollary or kind of addendum question to that is, where are we in terms of like, are there STIs that are on the rise that we should be aware of and paying attention to more?
Yeah, I mean, that's, we've hit upon one of those broad questions where I can probably talk. But I will, since everyone doesn't want to be here all night, I figured I'll narrow it down a little bit. So I guess maybe starting out with something that has been in the news a little bit, Mpox, and you mentioned this earlier, is making somewhat of a resurgence, at least in the past month or so. Last year, well, it first kind of made a splash in 2022 where there were 70 cases here, but 30,000 cases in the United States. They rolled out the vaccine, everybody became educated, and then the following year, at least in Allegheny County, there were only 2 cases, which was wonderful. And then this year, just within the span of about 3 to 4 weeks, 11 cases sort of popped back. And so everybody got very excited, and we were very busy dealing with these cases and trying to figure out, okay, is this the beginning of a very large kind of peak of cases, or is this just sort of a kind of contained outbreak? And fortunately, and I can't say too much because it's only been about a week and a half since our last case, it seems to have like calmed down a little bit. But as we head into Pride and as people travel a lot during the summer months, it could certainly come back. And so I think it kind of, I guess we sort of go back to our previous guidance that, getting vaccinated if we are at risk for Mpox becomes really important. That's what the CDC is trying to put forward, is like, okay, if you haven't been vaccinated for Mpox, if you think you might be at risk for Mpox, you should go get it. It's become actually, before it was coming from national stockpile, the vaccine, so it was actually hard to get. Now it's actually available commercially, and so it should be more available now. So I think that's probably the most effective thing that we can do in terms of trying to fight Mpox, is to get vaccinated if we are eligible.
So to kind of put a finer point on it, does that mean we can go to our local pharmacy and get that now that it's commercially available?
Yeah, so unfortunately it just became commercially available, I think, like literally a couple weeks ago. So I think everything sort of, there is a bit of a lag time. So I think eventually, my understanding is pharmacies should be able to carry it, and I think that's what we're working towards. Right now, I think, like, for example, if you're in Allegheny County, or actually in the United States, there's actually a Mpox vaccine finder that you can find on the CDC website that allows you to find a vaccine, a place that's offering a vaccine. Here, I'd probably say the community clinics like Central, Allies for Health and Wellbeing, and then the health department are great places to start out with. They're not the only places, but they're the ones that come to mind.
Fantastic. And so of those, kind of circling back, what do you feel like beyond monkeypox are the kind of dominant STIs that we should be concerned about in the community?
Yeah. I mean, there's probably several of them, but syphilis, for example, is surging again as well. And we've actually seen that, I think, well, within Allegheny County, actually, when you just look at the 2022 data, it actually dropped a little bit, but previous to that, it had increased by about like 90%. So it went up 90%, it dropped 16%. And now across the country, we're actually seeing a lot of increases as well. And so I think that speaks to kind of reinforced efforts being put into STI prevention. Also, I think important to look at which populations are affected. And so, yes, I think the LGBTQ population, especially gay and bisexual men, very much affected. But I think seeing it more in men and women who have sex with, so heterosexual men and women too. And then actually cases in babies. So it's not just an LGBTQ problem, it's a problem for really anybody who is sexually active.
And so when we think about kind of the big ones, syphilis, gonorrhea, chlamydia, and now we can add monkeypox, unfortunately, to that mixture of it. What are kind of the best case recommendations for getting tested and making sure that you know your status?
Mm-hmm. Yeah, theoretical lots to say about this too. So how do I focus this? A lot of the community and sexual wellness clinics, I think, are actually really they've developed a lot of expertise in this particular space. So they know how to do all the STI testing. They know that, like, for example, for gonorrhea and chlamydia, you don't just check one site, you actually check 3 different sites, whether that's throat, the genital region, and the anal region, because it can exist separately in all those parts. And so it's like kind of having an awareness and an understanding of how these STIs work. Primary care is great. Ideally, we take this knowledge and sort of apply it to primary care too, but we're not necessarily there yet. So that's one reason why going to these clinics, I think, is particularly beneficial. I think it's a combination of access to, where do you get the testing, whether it's in these community clinics, whether it's in the health department, or other spaces, as well as education so that people know where to get it, what they need to do. Because one of the things I've noted, especially as we've talked, as PrEP has become more available and talked about, is that you find patients teaching providers about, what is actually very current in terms of HIV or STI prevention.
Yeah. So your best recommendation is to go to one of the clinics. Also, the health department seems to be confident in being able to both do testing, but also to provide patients with a testing schedule based on whatever their particular needs are.
Yeah, I think so. Yeah.
You mentioned PrEP, so let's talk a little bit about PrEP, PEP, and DoxyPEP. Can you just for folks to just a basic overview, so folks know what each of them is, and kind of an overview of what the differences between them are.
Yeah, great question. So I guess so when we talk about PrEP is sort of the acronym for pre-exposure prophylaxis. And then PEP, which is PEP, and it sounds like PrEP, but it's not, is post-exposure prophylaxis. And so the whole concept, it's, we tend to apply it to usually HIV, but it can be applied to really any sort of infection or disease state. So the idea is like, okay, if it's PrEP, pre-exposure prophylaxis, you give that person something to prevent an infection before they get exposed to it, whereas post-exposure prophylaxis is after. So so basically the exposure happens, and then you're like, oh, I've been exposed. Now you take something after the exposure happens. And you can imagine that, like, there's a lot of different logistics and things that kind of come into play, whether you do it before or after. And it doesn't mean that one is necessarily better or worse than the other. It just is, but it's important to know kind of the difference. And so similar to DoxyPEP, Doxy refers to the antibiotic doxycycline, which we use a lot for acne or treatment of Lyme disease. So happens it's actually used as antibiotic.
Right. And so most of the time when we're talking about PrEP and PEP, we're talking about HIV prevention, at least in the queer community. And then when it comes to DoxyPEP, forgive me because I've heard different things. So there are some PrEPs that are now injectables, and so you can get them injected once every so often. I'm not quite sure when that is. And then with DoxyPEP, it's a course of medication that you take before and or after. So yeah, so you could take you take a couple of pills before you're going to have sexual relations, and then there's opportunities to take it after, right?
No, I'm so glad you bring this up, because as you can see, there's just a lot of confusion with the PEPs and the PrEPs and everything like that. So DoxyPEP, PEP, is the post-exposure prophylaxis. So the idea is you have sex on Monday, and then on Tuesday you might take a single dose, actually, to 200 milligrams of doxycycline, and that's it, actually. If you were to say DoxyPrep, then I think the idea is, well, maybe you are on doxycycline, like maybe you're taking a low dose of it every day, which is not as well established or studied, but if you mention DoxyPrep, that is technically the concept, and it's been studied a little bit, but most of the medical data that we have is actually for the PEP, the PEP, the taking it after sex. Some people happen to be, for example, they're taking doxycycline for acne. So that is sort of a form of doxy prep, theoretically. So is it being recommended yet? I don't think we're there yet. I know doxy PEP, the CDC has drafted some guidelines, so we know this is kind of in, it's on the list of coming attractions. It's being, I think, reviewed right now, and will probably come out, I think, this summer or the next several months.
And to put an underscore here, this is for any kind of sexual contact, because the doxy PEP is basically helping to deal with anything other than HIV, right?
Yeah,
right?
It shouldn't have any impact on. So the idea is that doxycycline, it's used to treat syphilis and chlamydia, and so it actually does work to protect against those two, because that makes sense. Bacterial STI, so it's not going to work against herpes or HPV, but gonorrhea, chlamydia, syphilis, it seems like there is some evidence for benefit there.
Anything else in the kind of infectious disease space that we haven't talked about yet that you wanted to kind of cover?
Yeah.
And we'll move on.
Yeah. I mean, you were mentioning, I guess, just going back to PrEP. So PrEP is now, used to be new, now it's becoming a little bit more mundane. But you were mentioning the different forms. So kind of classic standard PrEP is actually usually a pill, once a day pill. So we're thinking one called Truvada, or the long name is FTCDF, or emtricitabine tenofovir disparfovir, which is a lot to say. So everyone just says Truvada.
I'll say Truvada.
The other one is Descovy, which is actually very similar. It's emtricitabine taf, which is tenofovir alafenamide. Not quite as bad, but still a mouthful. So,
and this would be for someone who is HIV positive. They would be taking a full dosage of that on a regular basis for keeping their.
So Truvada is part of the full HIV treatment. So Truvada by itself is not full treatment, but it is oftentimes used. So both Descovy and Truvada are forms of prevention. So it's almost like you took kind of part of a full treatment dose and you kind of are giving it to people, which kind of makes sense. I'm sorry. And so with if somebody has HIV, they will get, in addition to those medications, more medications as well. So that we won't necessarily have the time to go into that. So when people are on PrEP, they're usually taking it. If they're taking oral PrEP, they're usually taking sort of part of what is treatment for HIV. But if somebody had HIV, you would take that, and that by itself is not sufficient.
Gotcha. So in addition to that, what are the concerns around, for example, liver toxicity and that kind of thing? So if someone's taking a daily pill of something like a Truvada or Descovy as PrEP, are there concerns there? Should people be?
I'm so glad you brought that up, because that comes up so frequently, and we never actually loop around and talk about that. So if you look at the package inserts and the kind of the list of side effects for these medications that are used as PrEP, they do list life-threatening liver toxicity as one of the side effects. But if you actually go to the guidelines as to how we prescribe these things, it actually says nowhere that you're supposed to even check liver enzymes. And so how does that make any sense, right? So a lot of the liver so you were mentioning earlier, these medications were used to treat HIV, and they still are. But back in the day, when we first started using these medications, they were seeing liver toxicity, I think, a lot in people who had hepatitis. There was a lot of hepatitis B and HIV. So when we started using these medications to treat people who were living with HIV and also had hepatitis, the ones who had hepatitis and who had pretty bad hepatitis, it was to some extent treating the viruses, but it was also causing a lot of inflammation. And so people were having really, really severe side effects because of all the inflammation from treating the virus, essentially. And so that got kind of recorded as side effects that could be dangerous from a liver standpoint. We don't really see that much anymore, number one, because hepatitis is much rarer. We're vaccinating. We're better at screening for it. And people are also getting diagnosed with HIV much earlier on. They're not waiting until they're really sick. And so treating doesn't seem to, I've treated so thousands of people who have had HIV, and, I've never seen kind of liver toxicity happen kind of the way it used to.
That's fantastic, and it's good to know and get that out to the community that don't have to be concerned about that when it comes to it, because it's certainly something that I thought about when it first came up. My grandmother passed away from a liver cancer, and so it was a concern of mine. Like, is this going to really affect me? Clearly, it's not.
I mean, we think about it still. It's in the back of our heads, but it's not like to go on these medications in healthy individuals. That's actually not mandatory to check liver tests or even to check them while you're on it. But if somebody has liver disease, a lot of doctors are like, it's still like a chemical. Could it have an effect? Yeah, I guess that is possible. And so sometimes people will check, and that's up to them.
Gotcha. Let's switch gears then. I want to talk a little bit about kind of communications and folks who are in relationships. How do folks who are LGBTQ plus have open and honest conversations about their sexual health, even in circumstances where you may have, say, casual sex with someone and you find out that you have an STI post sex? What are some good guidelines? I know that you're a clinician, you're not necessarily a counselor, but you must come into contact with lots of people who have experienced this. What are some guidelines people can use to have that conversation?
Yeah, I mean, it's really challenging because when you think of like the medical establishment, there's communities in general, the sexual stigma is really, really kind of rampant. And so it's hard to have a conversation where you're worried you're just going to get shut down from the beginning. And so I guess for me, starting out with like, okay, like, especially if, I try to come from a standpoint where like, I am sex positive, people can talk about whatever. I'm not going to be like, oh my gosh, you did that. You know what I mean? Like,
right, exactly.
And, but the thing is, you see that kind of, you just see it because guess what? We actually have never taught this in medical school. We sort of learn to walk into that space, so to speak. And I think I've realized that, coming from that perspective, I think patients really do open up. And so I think similarly as a community, as friends or what have you, to kind of be open to all sorts of sexual partnerships because they do exist. But then we're sort of taught to believe that only like one or two types are socially acceptable. So I suppose, we can all do our part as a community to kind of allow space for people to be able to share what they want to share. Because to do that, I mean, it requires a good amount of vulnerability to begin with.
Right.
And so I guess, from the patient standpoint, what to do, I guess, is to find either a provider who they trust and they can share these, share these experiences or questions with, or even sometimes people in the community. Oh, this is somebody who has a relationship that I kind of aspire to, what have you, and to speak to them and to kind of almost like kind of mentorship.
Yeah, I think it's really important for us all to remember that we are, as you said, we're a culture to talk about sex as a taboo subject, and we need to kind of remove that from society individually, right? We have to take that upon ourselves, and I think it's really important for us each to just sit down and think, who's someone that I can trust to have that conversation with and to open up that dialogue, and I think it can be really, really useful. Ross, if you don't mind, Julie's waiting outside. Okay, so when we talk about specific sexual health concerns between not specifically, but generally same-sex relationships, what are some ways in which we can navigate opening up those conversations and those conversations? What do you? Like, how do you have that kind of conversation with a partner?
Yeah, I think sometimes, and once again, I'm not a counselor necessarily, but I feel like I have a lot. We're sort of like, I need to get my point. I need to get my point across, and sometimes we do that at the expense of the other person who's sitting there across from us. And what I have found that works well is to kind of, before putting